Good evening, delegates and participants. Thank you for joining Shield Connect. And today we have Dr. B Anitha. Ma'am is going to take topic Placenta Previa APH. Before we start with the session, let me give a little introduction. Ma'am has done MS BGO in obstetric and gynecology. Ma'am is senior assistant surgeon in government headquarter hospital of Kanchipuram in Tamil Nadu. So we welcome you, ma'am, on our platform for today's webinar. Thank you, ma'am.
Yes. Thank you for an introduction. Okay.
So,
today's our yes, sir, audible? Hello.
Yes, ma'am. Yes, ma'am.
Okay. Today we will discuss about placenta previa, which is our it is a well-known topic. It is just refreshing for newer techniques. What are the things we? It is just a refreshing, and we can see some newer classification and the techniques in the placenta previa. Okay. Okay. We have already known what is meant by APH, antepartum hemorrhage. It is defined as a bleeding from or into the genital tract after 24 weeks of gestation, and it is prior to the delivery of the baby. What are the, if you see the, what are the causes for the APH, you can classify according to the placental bleeding, unexplained and extraplacental. If you come into placental bleeding, it is 70% of the APH is mainly due to the placental bleeding. Both placenta previa and abruption placenta shares the equal incidence, that is 35% on both sides, and unexplained is 25%, and extraplacental, which is more common nowadays, that is due to the cervical polyp, carcinoma of cervix, and varicose vein. This is the placenta previa. You can see the normal placenta, umbilical cord, uterine wall, and the cervix. You can see the placenta previa is a placenta in front of the baby, presenting part. What is the definition of the placenta previa? Where the placenta is implanted, whether it may be a partially or completely adjacent to the internal loss. This is called as placenta previa. If you see the incidence, nowadays the incidence of placenta previa is getting more and more due to the increased rate of cesarean section and also any previous uterine manipulations. That is, incidence, it increases to 3 to 5 per 1,000 live births and 0.5% among the hospital deliveries, and 80% it is more common in multiparous women, and it is increased beyond the age of 35 and the multiple pregnancy, where the placental volume is increased. If you see the classification, you can see it is a recent classification: complete placenta previa, partial placenta, marginal, and the low-lying placenta. Complete placenta previa, it is nothing but it entirely covers the internal cervical loss, and it partially covers the internal loss. If you have, it is very, very important. This is very easy to diagnose, complete and partial. It is very easy to diagnose based on the ultrasound finding. If you see the marginal placenta previa, it is very difficult to diagnose by ultrasound. It is very tricky. It is very important to diagnose a marginal placenta previa, where one edge of the placenta extends to the edge of the internal loss but does not cover it. It just touches the internal loss. Where lower-lying placenta, it should be in the internal lower uterine segment but within 2 centimeters of the internal loss. This is the placenta previa types according to the ultrasound. This is normal placenta, lower-lying placenta, where the edge of the placenta lies in the lower uterine segment and it is 2 centimeters away from the internal loss. Partial placenta, it partially covers the internal loss, and this is total placenta previa, where entirely it covers the internal loss. These are the recent placental previa types. We can see the type 1, type 2, and type 3 and type 4. It is already known. Here the type 1 is very important. That is A and B. That is 2 subdivision, anterior and the posterior. What is meant by dangerous placenta previa? It is nothing but placenta type 2B, where the curved birth canal, major part of the placenta lies in the sacral promontory. Here there is an important one sign is called as Stallworthy signs. When the head of the baby compresses the placenta and it causes the uterine and it causes the CTG variations. What are the risk factors for the placenta previa? I'll really explain. is due to the multiparous increased maternal age, previous LSES, previous placenta previa. It is tenfold increase in the next time. There is a tenfold recurrence of the placenta previa and multiple gestation. And the it is mainly due to the deficient due to the presence of endometriosis, manual removal of placenta, and the submucous fibroid. Then when you see the etiology, yes. Etiology is mainly due to the dropping down theory. Sir, hello.
Yes, ma'am. We can hear you clearly.
Yes, okay. Etiology, you come into the dropping down theory due to the poor residual reaction in the upper uterine segment. Fertilized ovum drops down and gets implanted into the lower uterine segment. What is the main reason for placenta previa is the persistence of chorionic activity in the decidia capsularis, and defective decidia results in the spreading of chorionic villi, and there is a big surface area of the placenta as seen in the twins. What is the main factor for the placenta previa is the lack of placental migration. What is that placental migration? Due to the differential growth with the progressive increase in the length of lower uterine segment, the lower placental edge relocates from the cervical os. Due to the tropotrophism, the growth of tropoplastic tissue towards the fundus, there is a resolution of placenta previa. This is very, very important. At 16 weeks of incident is 20%. Only at 40 weeks, it is 0.5%. So placental previa diagnosis should be at the later gestation, mostly at the third trimester, not at the first. For most of the placenta will be in the lower segment in the first trimester scan. What are the pathological changes you see in the placenta previa? It may be a large and it is thin, and degeneration, infection and calcification will be seen. The lower uterine segment, due to the increased vascularity, the lower uterine segment becomes soft and fragile. What's the main for the bleeding in placenta previa? What are the causes for bleeding of pathological changes? Placental growth slows down in the later month. Why there is a bleeding in placenta previa? It is mainly due to the lower uterine segment, which is progressively dilates, and inelastic placenta sheared off from the wall of lower uterine segment. There is an opening of uteroplacental vessels, and which leads into the bleeding. This you can see in the diagram. This is the formation of lower uterine segment. Here there is a lower edge of the placenta, gets sheared from the lower segment, and avulsion of villi from the stretching of lower uterine segment, and which causes bleeding into the vagina. What is this type of bleeding? It is called as warning signs of hemorrhage. What is the main reason for spontaneous control of bleeding? After that, here the placenta previa, only the main differentiation between the abruption and placenta previa, there is a stoppage of spontaneous control of stoppage of bleeding will be there. What is the reason behind? There is a thrombosis of open sinuses, and there is a pressure by the presenting part and the placental infarction. This is the classical features of the clinic. What are the clinical features you will see in the placenta previa? We have already known it is a sudden onset painless bleeding. It is very, very important. In abruption, everyone knows it is a painful bleeding, and placenta previa, it is a sudden and painless and recurrent bleeding will be there. So you see the signs. The uterus size of the uterus will be correspond to the period of gestation. And uterus feels relaxed, soft and elastic without any localized tenderness. Tenderness will be present in abruption placenta. And there is a persistence of mal presentation. It may be due to the in the lower uterine segment, there is a placental encroachment. This leads into the lack of rotation, failure of rotation of the baby, and leads into persistence of mal rotation. Head will be floating in contrast to the period of gestation. If you see the FHS, here in abruption, these are the signs. FHS will be usually present even in the profuse bleeding. Even in the profuse bleeding, FHS, there is no, it will be present. There won't be any abnormalities will be present, except in the Stallworthy sign. I have already explained in the posterior type of placenta, due to the presence of pressure, due to the cord compression, it leads into the CTG monitoring and placental FHS variation. What is the local examination you will see in the placenta previa? It is vulval inspection. Here you can see the it is very, very important. What is the color of the blood in the placenta previa? Usually bright red blood occurring from the separated uteroplacental sinus close to the cervical opening and escape out immediately. In abruption placenta, the color of the blood will be altered. The vaginal examination should be done without confirming the placental position. How will you diagnose the placenta previa? It is from the history. It is a painless and recurrent bleeding present in the second half of the pregnancy, usually unless it is provoked. How will you confirm? It's easy to confirm due to previously it is only by clinical examination. Nowadays we are in the era of the ultrasound era. You can confirm it by the third trimester scan, that is 34 to 36 weeks. Ultrasound, TVS, color Doppler, and then MRI you can do by rule out placenta accreta. It is useful to rule out placenta accreta. It is very, very essential. If you diagnose placenta previa, you have to rule out placenta accreta. Okay. Clinical examination, it is a previous school of thought. It is a double setup examination. Nowadays it is gone up. No rule. It is then trans-abdominal accuracy after 30 weeks. It is 90%. So placenta previa diagnosis should be at more than 32 weeks. Then only you have to label it as placenta previa. Then transvaginal probe, it is very close to the target organ. It is more accurate than the TAS. Transperineal, it is not useful. This is the ultrasound finding of placenta previa. You can see the lower edge. It is encroaching in the lower uterine segment. Color Doppler, you can see areas near the cervix and is consistent with the diagnosis of placenta previa. It is the next one, clinical confirmation of placenta previa. This is a clinical confirmation of placenta previa by the double setup. Nowadays, we are not less frequently doing nowadays. You can visualize the placental implantation in the lower uterine segment and confirm during cesarean section. What are the differential diagnosis of placenta previa? It is, we have already known, vasa previa, where the fetal vessels will be present in the lower uterine segment, and local cervical lesions and circumambulate placenta. What are the complications you will see in the placenta previa? It is a major cause of major hemorrhage and shock and the death, and anemia in the chronic hemorrhage. If you get prolonged bleeding in the first and second trimester, you will have the recurrent anemia. You will have the resistant anemia. And then the baby, the mother lead into PPROM, PROM. Then it is more morbid adherence of placenta, which is 10% of placental previa. It complicates sensitization and cesarean section, PPH, and renal tubular necrosis and acute renal failure due to the abruption placentae. What are the fetal complications? Most of the mother lead into preterm labor, and there is a chance of low birth weight, and IUD will be more common due to the severe degree of placental separation, where the abruption placenta is more common in the associated with placenta previa. How do you manage? Management part is very, very important. There are four modalities of management. One is emergency cesarean section, conservative in hospital observation, vaginal delivery where type 1 and type 2 placenta previa, where vaginal delivery can be allowed, and scheduled cesarean section. If you see the management, mainly it is very important to give the adequate prenatal care is very, very important, and antenatal diagnosis of low-lying placenta is very important in the by ultrasound diagnosis. And there is a significance of, you should explain the warning hemorrhage to the patients. It is very, very important. And you have to explain about the family planning and limitation of birth. Once the placenta previa in the primi gravida, there is more chance for 10% fold increase in the next pregnancy. What are the things you have to do in placenta previa? You have to assess what is the amount of blood loss, and blood sample should be taken for grouping cross-matching HP. And also you have to put a large wide bore IV cannula and the general shock management like airway, breathing, circulation, and you have to confirm the patient with the history of torrential bleeding. And you have to arrange the ultrasound scan, which is the continuous electronic fetal monitoring is very, very essential. What are the type of, what is the formulation of line of management? One is expectant management, another one is active management. What is the expectant management of placenta previa? You have to deliver at the tertiary care center where there is availability of bed for transfusion, and there should be a facility for cesarean section. We need of senior consultant should be there for the PPH management also be there. You should ensure while conducting the placenta previa delivery. What is the selection of cases? The HP should be more than 10 and hematocrit is more than 30%. You can go with the expectant management, and duration of pregnancy should be 37 weeks. If there is a 37 weeks completed, you plan for cesarean section. There will not be any active vaginal bleeding. What is McAfee's Johnson's regime? It is mainly expectant management of the management in the placenta previa, where we have to wait for the baby to get mature. You have to advise for the patient bed rest, and investigation should be HP and PCV. You have to monitor, and periodic inspection should be there. You have to correct the anemia. Patient should allowed out of bed only for the only if it is necessary. Only the patient should go out of the bed. And use of tocolytics and cervical insert cloths, nowadays it is not at all useful. Tocolytics, it is not at all useful. When you will terminate the expectant line of management, there is carried up to 37 weeks. When pregnancy up to 37 weeks, you have to plan for termination, and this by this time the baby becomes mature. And when you will go for premature termination, when there is any brisk hemorrhage and suspicion of placenta previa, abruption placenta, when the fetus is dead and there is any congenital malformation, there is no need for expectant line of management. And then steroid therapy, it is indicated when the duration of pregnancy is less than 37 weeks. And betamethasone is reduces the risk of respiratory distress. That we know. What is the active management of active management? What is the role of active management when there is bleeding occurs at or after 37 weeks, and patient should be in the labor, and patient in the shock, extreme shock, and bleeding is continuing and moderate degree, you have to go with active management irrespective of the gestation. What is the definitive management? Nowadays, it is not followed. Vaginal examination in OT followed by low rupture of membranes or cesarean section. Vaginal low rupture of membranes conducting the vaginal delivery in the type 1 and type 2 placenta. And cesarean section, we come into what are the contraindication for the vaginal examination. If it is, we have already known whether it is a major degree of placenta previa and associated with elderly priming gravida, malpresentation, contracted pelvis, there is no role for vaginal delivery. These are the precautions to be taken for the vaginal delivery. Steps to restore the blood volume and examination of cervix should be done. What are the indications for cesarean section? One, there is a severe degree of placenta previa, that is type 3 and type 4, and lesser degree of placenta previa where amniotomy fails to stop the bleeding or fetal distress appears. And complicating the factors associated with the lesser degree of placenta previa where vaginal delivery is unsafe. Prognosis. Reduction of maternal death in placenta previa is mainly due to the early diagnosis, omission of the internal examination, free availability of the blood transfusion facility, potent antibiotics, and use of cesarean section. This is the placenta previa. In placenta previa, is management of placenta previa. Sorry, that slides is not able to shown here. It is mainly due to the Watts procedure. By the how you will do cesarean section in placenta previa, there it is two techniques. One, it is previously followed by Watts procedure, where we are cutting the placenta and delivering the baby. Nowadays, we are not cutting the placenta directly. You are poking the hand into the internal os and the behind the lower edge of the placenta should be cut out, and you have to rupture the membranes. And first we have to deliver the baby, and then only you have to deliver the placenta. That here there should not be any manual removal of placenta, should never be attempted. It leads into the leads into atonicity of the lower uterine segment. So you have to wait for the spontaneous detachment of the placenta. This is the vasa previa. You can see vasa previa. Fetal blood vessels and from the placenta or the umbilical cord which crosses the internal os and beneath the baby. What is meant by vasa previa? This is the normal condition of the vasa previa. Here the destruction of the umbilical cord and distension of the umbilical vessels, the extension of placental tissue resulting in multiple lobules. This is the where the fetal vessels will be outside the membranes. What are the risk factors for the vasa previa? It is mainly due to the vellum-temes cord incision and the bilobed and suction straight lobe of the placenta, multiple gestation, placenta previa. This is vasa previa. Here, what is the take-home message is all women with placenta previa or the low-lying placenta have increased risk of morbidly adherent placenta, particularly who have the previous cesarean section. And women with and if there is any history of APH, first episode if it is less than 29 weeks or the recurrent episodes more than 3, or thick placental age covering or close to the cervical loss and short cervix and previous cesarean section are the risk factors associated increased risk of urgent and the preterm cesarean delivery. For these cases, you should not wait up to 37 weeks. The absence of risk factors, outpatient management of placenta previa is safe. Main thing you have to advise for the patient is bed rest. Reduced activity is not beneficial in women. Reason it is there is no reduced activity is not beneficial in women with placenta previa and can be potentially harmful. However, you should ask the patient to avoid the sexual intercourse, and incision of the foreign bodies into vagina and rectum should be avoided. Pre-operative bedside ultrasound assessment of placental location is very, very important. And then it is planning for the surgical technique. And regional anesthesia, mainly you have to get consult from regional anesthesia is safe. Previously, general anesthesia is given. Now, regional anesthesia is safe. And it is adequate for the first line anesthetic approach. And if the patient goes for pericardium hemorrhage, you have to plan for general anesthesia. When deciding the location of the delivery, consider the ultrasound assessment of placenta location, any risk factors, and patient history and logistic factors, including the resources at the delivery unit you have to see. What is the few messages about few things about the placenta accreta spectrum? It is first described nowadays. Placental accreta is increasing trend. It is increasing trend. Mainly, it is first described by Irving in 1937. Why? What is the reason for placenta accreta? It is mainly due to the invasive placentation, which leads into catastrophic hemorrhage. These are the types of placental accretal spectrum: accreta, increta, percreta, and morbidly adherent placenta. And it starts from 0.8% per 1,000 deliveries in 1980. Nowadays, it increases 3, which is a huge amount per 1,000 deliveries. What is the pathogenesis behind the placenta accreta? Is the normal placenta usually does not go beyond the inner third of the myometrium through the tight and the partial temporal regulation, where the proposed hypothesis includes here there is an absence of residue or the basal plate or abnormal or maternal vascular remodeling and excessive extravillous. It is nothing but the excessive invasive encroachment of the placenta into the myometrium and excessive extravillous tropoplastic invasion. These are the reported pathological association with the, these are the reason for the placental accretal spectrum disorders. One is a direct surgical scar, that's cesarean section, any dilatation and curettage, myomectomy, endometrial resection, and non-surgical scar is mainly due to the IVF procedure, recurrent endometritis, intrauterine device, manual removal of placenta, and uterine anomalies is mainly due to the biconvex uterus adenomyosis submucous fibroids. How will you diagnose the placental accreta? It is mainly by ultrasound, which is a basic MRI is the diagnostic feature for the, it is a confirmatory diagnosis for the placenta accreta, and you can simply diagnose by ultrasound with color Doppler. In the color Doppler, you can see the disappearance of the normal uteroplacental interference, that is a clear zone, and presence of lacunae within the placenta and placental hypervascularity and extreme thinning out of myometrium. And another feature that is very, very important is the bladder and lower uterine segment interface will be normally it is bulged. In placenta accreta, it is flattened and it is irregular. In MRI, 80% of located, it is very useful in diagnosing the upper, which is very difficult in diagnosing in the ultrasound. MRI, it is very important to diagnose in the near the upper posterior bladder wall. How will you manage? It is mainly by the multidisciplinary team, which includes the obstetric anesthetist, oncologist, and interventional radiologist, urologist, and transfusion. Transfusion department is very, very important. These are the treatment option modalities for the placental accreta syndrome. One is a hysterectomy, ablative technique, where it is very difficult to do. Future pregnancy is not available. Here, the recent advancement is a triple P procedure and one-step conservative procedure. What are the conservative methods you will see? Leaving in the placenta in situ and one-step procedure, one-step conservative procedure, and then triple P procedure. What is the leaving placenta in situ? Delivering of placenta through the uterine incision without involving the uterine fundus. If it is fundus, you should not touch the uterine fundus. Uterus is closed and placenta should be left in situ and should be spontaneously absorbed. For this patient, the patient will be, it should be in the higher antibiotic coverage. Mostly the patient goes into secondary PPH and there is a more risk for, again, patient may go into the hysterectomy. So nowadays, leaving placenta in situ is banned. It is not practiced. What is the procedure? This is to reduce the Risk of obstetric hysterectomy in placental accretal spectrum. One is first, what are the things you have to do? One is the peri-operative placental location of the superior edge of the placenta. You have to identify where is the superior edge of the placenta, and placental devascularization can be done with an arterial balloon catheter, which should block the anterior division of internal iliac arteries, where anterior division includes the uterine artery. There should be no attempt to remove the entire placenta with large myometrial excision. That should not, you should not, you can attempt to remove the entire placenta with large myometrial excision should be done. With the entire placenta, you can take out the some part of myometrial tissue, and then you have to close the uterine repair. Then you have to close. If posterior wall of bladder is involved, the placental tissue involving the bladder is left in situ to avoid cystotomy. If it is very difficult to handle this posterior wall of the bladder, if placenta involved in posterior bladder. What is meant by peripartum hysterectomy? That is performed during the complication or the complication of vaginal delivery, and which is carried out within 24 hours of delivery. This is the incidence of emergency peripartum hysterectomy. Main reason for peripartum hysterectomy is mainly due to the abnormal placentation. What are the risk factors? These are mainly morbidly adherent placenta. The only mode of it is a main reason for the peripartum hysterectomy. Okay, this is the type of total and subtotal hysterectomy. What are the complications of hysterectomy? You can see maternal morbidity range from the 26 to 31%, and complication include retransfusion and febrile episodes and the perinatal death, and bladder injuries are more common in a morbidly placental, adherent placenta, and wound infection, DIC. Patient may go for DIC. That's all, sir.
Yes, ma'am. Yes, ma'am.
Yes. Any doubts?
Yes, ma'am. 1 minute. So, ma'am, there is one query that whether patient can do any kind of exercise if the patient is detected with this issue.
Yeah, actually in type 1 and type 2 you can allow for type 1 and type 2 you can allow for mild antenatal exercise can be advised. In complete and partial placenta previa, you have to advise for bed rest.
What's your diet recommendation for such patient, ma'am?
Diet recommendation is same for every patient, but you have to frequently monitor, check the HP. HP estimation is very important, since these patients are more go for blood transfusion. To avoid that, you have to go with correction of anemia is very, very important. You can take same calories and iron, but you have to check frequently. HP estimation is very important.
I cannot find any more questions from delegates. Thank you for making us this webinar possible. Yes, ma'am, it's okay. So, but at last the webinar went so well, and the topic was discussed in very detail. So we are glad to have you on our platform, and you gave your precious time on Shield Connect, ma'am.
Yeah, thank you so much.
Next
time we won't find any internet connection difficulties. Thank you.
Sure. Thank you, ma'am.
Thank you, ma'am.
Thanks.